Hi guys, sorry for the delay. This is Dr. Anita Call. This is my first attempt at a virtual teleconference. So it's a completely new experience for me. So a little bit technical difficulties to get all these things set up. But hopefully this goes smoothly. Just to remind you guys, I cannot see you guys or I cannot hear you either. So feel free to relax, move around, do whatever you're doing while you join us. And if you need to ask questions, there is a button on your computer which shows Q&A. You can send your questions through that, and the questions will remain anonymous, so I don't know the name of the person, so don't worry about that. And I'll try to look at the questions towards the end of the talk, and we will at that point go through the questions so that normally I know I make it very casual. We discuss as we are talking, but it's a little bit different experience through the virtual thing. So it'll be a little bit easier if we leave the Q&As towards the end of the thing, okay? So again, introducing myself, I'm Dr. Anita Call. I'm a medical oncologist, hematologist with UCLA here in Westlake Village, as well as in Porter Ranch. Today I'm talking to you from Porter Ranch, which is Tuesday. And so let's just get started. All right, so, I'm sure many of you guys have personal or indirect experience with breast cancer, patients or family members, friends, or a general interest. It's a very common cancer, as you guys are aware, because almost 1 in 7 women will develop breast cancer sometime in their lifetime. And as we get to the middle age group, I'm in part of that now, between 50 to 65 age group, 70 age group, almost 1 in 4 women will get diagnosed with breast cancer. So pretty significant incidence of breast cancer. And it's also to emphasize the point that we need to stay vigilant. We need to, even if there is no family history, even if you don't think you fall in the high risk group, need to do regular screening. It's very important. Self-exam, mammograms, all those things need to be done, and please continue to do that, okay? So how do we approach breast cancer? So first of all, in any cancer, we want to know the stage of the cancer. So broadly speaking, and here I will get into a share screen mode so you can see some of the slide, and here it is. 1 second, okay. So yeah, this is just my introduction. And yeah, so any cancer, we want to look at the stage of the cancer. The early stages are where our goal of care is still to cure the patient, hopefully. So our approach is very different when the cancer is stage 4, which is metastatic cancer. Then of course we know we cannot cure the cancer. And in today's circumstances, for any solid cancer, lymphomas, myelomas, leukemias are different story, but for breast cancer and other solid cancers, stage 4, our goals are to control the cancer and to maintain the patient's quality of life and prolong survival. So how we approach cancer does depend on the stage of the cancer, and how, the goals depend on that. All right. So I'm going to go to the third bullet point on this slide, which is the tools of care. So we'll be emphasizing and talking a lot about systemic treatment, but I do want to mention briefly surgery and radiation. Surgery is mainly part of the management of early stages of cancer, meaning stage 1, 2, and 3. Stage 4, usually, unless we need to control some symptoms, surgery is usually not warranted. So if somebody has a small primary in the breast, but there's widespread cancer, then removing the breast cancer by itself doesn't achieve anything. So surgery may not be warranted. And radiation, again, it's usually can be part of early stage breast cancer in trying to get local control in addition to surgery, depending on the kind of surgery and the extent of cancer patient has, but usually not part of stage 4 cancer, but that actually has a lot of exceptions. A lot of breast cancers like to go to the bones and in stage 4 situation, and we may need to use radiation to relieve pain, and also sometime radiation of some other area. So those modalities may also get used in those areas. Okay, so in terms of systemic treatment, I will be talking about situation where we are using it. Okay, Adjuvant is when the patient already has had surgery for the primary cancer. Let's say it's stage 1, 2, or 3, or I'll broadly say early stage for all of them. And if we are giving systemic treatment after the surgery, that is called adjuvant, okay? And that's separate from neoadjuvant. What that means is we are giving chemotherapy or some other treatment before the surgery, and then doing the surgery after the initial treatment. And palliative just means that surgery is not the issue here. We are doing treatment in ongoing basis, and the idea is to control tumor and control symptoms and prolong survival. So those are the terminologies that are used into as to when these treatments are being used. In terms of deciding as to what form of treatment we use, it really depends on the biology of the tumor and where we are. So biology speaking wise, there are basically three main categories. The first one, the most common one, which accounts for 50 to 60% of breast cancer and even more in some populations, that is hormone receptor positive. What it means is these tumors will respond to hormone directed treatment. And the two hormone receptors we are mostly looking at are estrogen receptor and progesterone receptors. And if the tumor is positive for that, then we are talking about hormone responsive breast cancer, and we may be using that as part of the systemic treatment. The third receptor we look at very often is HER2/neu, her like for a female, HER2 and NEU. And these receptors are present in almost 20 to 25% of the breast cancer diagnosis. And when these receptors are present, the treatment is mostly decided by them. Now, these tumors may, in addition, have estrogen receptors, or they may not have hormone receptors. So they can be two subgroups, but the first decision making is because of the HER2/neu, not from the estrogen receptor in that situation. And triple negative is basically by by exclusion, meaning these are the cancer where the estrogen receptors are negative, progesterone receptors are negative, and HER2/neu receptors are negative. So we basically are, we are basically going by the, whether these receptors are present or not. That doesn't mean these tumors do not have any receptors. These just mean that the receptors, these three receptors are negative, okay? So let's go to the share screen again, to my next slide. Sorry, this is, okay. All right, so the next slide here. All right, what kind of systemic treatments we are using? If the tumor is estrogen, progesterone positive, we are talking about hormone therapies. If they are HER2/neu positive, we are using HER2/neu directed therapy. And chemotherapy is something that may be used in all three kinds of cancers with or without those additional systemic treatments. So chemotherapies are not just for triple negative breast cancer, but also for hormone receptor positive, and also maybe are combined in HER2/neu directed therapy also. So, but how we are using it depends on the situation. Okay. Let's talk first about, I'm going to go backward here. So let's say somebody has an early stage breast cancer and they are, I'm going to go back here, and we are talking about timing of the treatment. If the tumor is hormone receptor positive, most of the time we will be doing surgery first in early stage cancer and then going to the additional treatments. The reason being that these tumors shrink slowly. So giving them treatment before the surgery will not shrink the tumor that fast, so will not add anything to that. Now, in certain countries where the patient may need to wait a long time for surgery, and to a degree it happened recently with the COVID-19, that some patient surgeries may be delayed, one could use hormone therapies to keep the tumor under control, keep it from spreading while the patient's surgery is being waited upon for some reason, okay? But usually practice in US is in the hormone therapies, sensitive tumors, we do that after the surgery in early stage cancer. Chemotherapies. Now, if a tumor is HER2/neu positive or the tumor is triple negative, if it is triple negative and it is small, yes, the patient can proceed with the surgery and we can talk about adjuvant treatments. But if the tumor is HER2/neu positive, unless the tumor is very, very early stage, even in stage 1, a small tumor, we very often may recommend doing treatments first. What that means is the patient may be getting chemotherapy as well as HER2/neu directed therapy before the surgery or in a neoadjuvant manner. Of course, that's really important if the tumor is stage 3 or locally, a higher end of stage 2. And also we have to look at is the size of the breast in relation to the size of the tumor, because the goal here is to shrink the tumor before surgery so we can clear up the axilla, we can shrink the tumor. In some cases, we may be able to save breast. In other cases, if the tumor was really higher stage 3, it may not be operable necessarily easily because of the muscle invasion, and the surgery can be morbid. And if we can shrink the tumor before the surgery, that makes the surgery much less invasive and the outcomes are much better. And the other reason why we may recommend treatments before is we get to evaluate our systemic treatment. So if we are using chemotherapy in a triple negative, we have different options, and we can actually see real-time response in that particular tumor to see how effective our treatment is being or not being, and whether we need to change the treatment. Similarly, if we need to do the HER2/neu positive tumor and we want to shrink the tumor so that we can, one, evaluate how effective treatment is and also make the tumor smaller. In a fairly large number of HER2/neu positive tumors and most of the triple negative tumors also, you can significantly reduce the size of the tumor, reduce the size of the lymph node, and in a lot of patients, you can get what is called complete remission, meaning when the surgery is performed and pathology specimen is evaluated, there is no evidence of residual cancer in the breast or the axilla. That is called pathological complete response. And that is usually a good marker that the patient's tumor has responded well to the treatment, and that actually also is a prognostic marker, meaning the patient will do well longer term. It also changes what we may recommend for the patient later on, meaning if there is not a complete pathological complete response, let's say in a HER2/neu positive tumor, then instead of just giving them Herceptin, we may choose to give them TDM1. I'll be talking about those things, but that is Herceptin along with the chemotherapy. Okay, so of course our management has changed, our systemic treatment has changed accordingly. And in the case of triple negative tumors, again, if we don't have a pathological CR, we may recommend some additional therapy depending on the response after the treatment. Okay, let's go to let's go to this again. All right, let me see. I'm sorry. My slide seems to have disappeared here for some reason. Okay, I think I will go on to, I will probably just stop share. For some reason, my slide is not visible right now. So I'll try to go without it. Okay, so let's talk about what are the possible treatments. I'll try again later on to see if the slides can be shared. So actually, this was the most important slide. So let me try one more second as I'm talking. So in a HER2/neu, in an estrogen positive tumor, what we are talking about is I'm going to just work on this while I'm doing this. My computer signed me out of my email. That's what happened. Let me just go open it again. Sorry if you are, I hope you can still see me, even though I can't see myself right now. But you know what? let's just forget about that. Let's just minimize this and go back to the talking without the thing. That's a shame because that's where I needed the slides most of all. So when we're talking about anti-estrogen therapies, we are talking about, of course, three categories of anti-estrogens. We have tamoxifen-like drugs. We have another group of drugs which we call as AI, or aromatase inhibitors. And then we have what we call SERD. The most common drug in that is Faslodex. What is interesting is now we are also looking for an oral SERD, which is similar to Faslodex, a little bit different, but it'll be in an oral formulation. And we actually have trials for that. And that will be nice because if anybody has gotten Faslodex injection, it's 2 injections intramuscular every month, definitely not something that anybody likes to have. So if we can get oral formulation, it will be nice. In terms of aromatase inhibitors, we have 3 drugs available, which is anastrozole, letrozole, and aromacin or estamastane. And then what has changed is, what has not changed actually is that when we have an early stage cancer and we need to decide whether this patient needs chemotherapy or not, and it is relatively early stage 1 or stage 2 cancer, we may get another assay which is 21 gene analysis to see if this patient needs chemotherapy. And we do that by doing something like Oncotype DX to see if patient needs chemotherapy. Otherwise, they complete their surgery, radiation, and may only need anti-estrogen treatment. When we are talking about hormone-directed therapy, we are many times using additional agents in a metastatic setting. So first we start with what is called CDK inhibitors. So these are used along with Arimidex-like drugs, or one of those drugs can be used along with Faslodex-like drugs also. And what they do is in advanced cancer setting, that's a first-line treatment for hormone-positive tumor, and they double the response of anti-estrogen. So you can increase the survival and you can keep patient away from more toxic treatments for much longer. And there are 3 of them available. Basically, let me try to remove that. 1 second. Something interfering in here. Hopefully you can't see it, even though I can. My computer, 1 second. This thing is trying to open up. Okay, so what we, oh my God, let me try to minimize that. Okay, we're back. Something happened on my computer again. What we are trying to do there is also we are trying to do some studies to use if we can use CDK in higher risk, earlier stages of breast cancer also, but definitely they made a big difference. Their response to anti-estrogen in advanced stage HER2 positive tumor is more than doubled. And so we can keep patients away from chemotherapy longer and prolong their survival. Once the CDK inhibitors stop working, we can of course change anti-estrogens. We can also add other agents. We test tumors and also circulating DNA for something called PI3 kinase mutation, PI3K mutation. And if they are present, which could be present in up to 40% of these cancers, then we have agents against that, and we can combine that with anti-estrogen treatments. And also, if the mutation is not present or later on, we can use another agent called mTOR agent, which is everolimus, and that is combined with an anti-estrogen. So all of these have their own share of side effects, and we need to, learn and teach patients how to manage those side effects. But what they are doing is giving us additional options in estrogen positive tumors before we need to go to chemotherapies, and also prolonging survival. And this list will keep increasing, okay? So chemotherapy, everybody fears chemotherapy, although some of the chemotherapies are fairly easy, but, as many options as we have, it really gives us a better quality of life and, a longer survival for the patient. So those are important. Other exciting developments this year has been in the HER2 field. Trastuzumab was approved, if I remember correctly, something like 1999. I remember during my early practice days when it got approved, and it made a big improvement in management of HER2 positive tumors, initially for advanced cancer, and then now, of course, we use it in adjuvant and neoadjuvant setting also. The second addition came a few years back, and that was another antibody called pertuzumab, which is given in addition to trastuzumab or Herceptin. Uh, and then what we again then we had was some of the oral drugs came about. Initially was laratinib, then neratinib, and now the new one is tucatinib. And what is exciting about tucatinib, and the recent data presented was very, very good. It's very effective agent. It can be combined with other agents, can be combined with an oral chemotherapy like Xeloda or capecitabine, and so it makes an oral regimen. And what is very exciting is it works very well even if patient has gone through multiple different kinds of chemotherapies and HER2 directed therapies. And another good part of this is that it does cross the blood-brain barrier, so we can actually make it work even in patients who have cancer, HER2 positive cancer spread in the brain. So that is, and the side effects are much less than they have been with our other oral HER2 directed pills that we have had. So that has been one additional tool that we got this year, and which looks very, very good. And the other one is we have had available what is called antibody drug conjugate. What that, or the short form is ADC. What that is the most common, the first one we started using in breast cancer was what we call short-term TD1. The brand name is Kadcyla. And TDM1, basically T stands for trastuzumab, so that's Herceptin, trastuzumab. Then it is attached with a linker to a chemotherapy. What is good about these antibody-directed chemotherapies are that they take, the antibody takes the chemotherapy right to the cancer cell, and the chemotherapy, and it does its own antibody work, and then the chemotherapy is released in the cancer cell itself only. So the patient has minimal, if any, side effects, at that point. So that makes it, much easier on the patient. The side effects are less. TDM1 has been available for a long time. We have been using in advanced metastatic breast cancer as a treatment option, and we still use it. But right now, another option that came about is a different one. And for ease sake, I will call it TDS. Okay, it's again trastuzumab, and DS is a different chemotherapy, and it has a different linker. It's a much better antibody drug conjugate, and it gives us another option. And what the studies have shown, it just got approved this year, and what the studies have shown is that its response rate is more than 60%, even in patients who have had multiple different treatments and have been on treatment for long periods of time. So a very effective drug. Some of the non-breast cancer tumors also can be HER2 positive. Gastric cancer is one example, and our other HER2 directed drugs have not been that great in them. And this drug seems to work in HER2 positive gastric cancers and other cancers also. So definitely it's a very exciting additional tool for managing HER2 positive tumor. One thing I did mention earlier, that in an earlier stage breast cancer, if the patient does not have complete remission after neoadjuvant chemoimmunotherapy, then we many times will recommend them TDM1 for about 10 months later on, instead of just giving them Herceptin. So that has been going on for a couple of years, okay? So all these are additional tools in HER2 directed treatment. We also are using sometime neratinib in HER2 positive tumors, which are also estrogen receptor positive, and adding that to an anti-estrogen in those patients added slightly to, it seemed like there was small benefit, although not a huge benefit, but that's an option available. Okay, let's get to the triple negative breast cancer. And for triple negative breast cancer, initially our focus has been chemotherapy, and there has been additional improvement in chemotherapies. What has been new has been a few different things. One, if the tumor has the immune marker called PDL1 or PD1, okay, which the tumor can be tested for it, we can give those and mostly it will be in triple negative breast cancer, but it may be present in others also. We can give those patients immunotherapy, which you might have heard about in other cancers. They have been very much used in multiple different cancers. But in this situation, we are giving them immunotherapy with a chemotherapy, usually a taxane or a platinum. Okay, so that's one important thing, that we can use immunotherapy in some of the triple negative patients, triple negative breast cancer advanced stage, along with the chemotherapy. Okay, we also know some of the triple negative tumors will respond better to platinum-based chemotherapy, like we use also in HER2/neu positive. Most of the estrogen positive tumors may not respond as well to platinum-based treatment. The other thing that came about is that we do know that triple negative breast cancers may express BRCA1, either if the patient has it or the tumor may have it, and some other mutations which behave like BRCA1 and may not be the BRCA itself. Also, BRCA2 can be present in patients which are triple negative, or they may be estrogen positive and they may still express BRCA2. Those patients, we can use PARP inhibitors. PARP inhibitors are oral drugs which are approved for breast cancer and for ovarian cancer and other BRCA carrier patients. There are other BRCA-like mutations like PALB2 and some other mutations behave like that. And there are times where the patient may not carry the gene, but the tumor carries the gene mutation, and we can use these drugs in those situations also. Of course, this is still a smaller portion of the breast cancer that we can use these agents in. In ovarian cancer, they seem to work in all ovarian cancer, irrespective of whether there is this gene present or not. But in breast cancer, so far, it looks like it's only if these gene expressions are present. Okay, but not just BRCA1 and 2, PALB2, and some of the other similar behaving mutations, these drugs may be effective. The other addition recently is a new drug. The brand name is called Prodev. These are hard names, so I wish I could show you my slide. But the other name is sacituzumab. It is, again, an antibody drug conjugate, and it attacks tissue factor which is present in cancer cells in triple negative cancers, but these are actually present in estrogen positive breast cancer also. At this time, this drug, which is sacituzumab, attached to a chemotherapy, only is approved for triple negative breast cancer, but can be used second or third line. So after patient has had only few cycles, or can be used later on. And then again carries the same concept. It's an antibody chemotherapy conjugate with the lung linker. So the antibody basically is taking the chemotherapy drug right to the cancer cell. So you're minimizing the side effects. So we're already using it in triple negative breast cancers in advanced situation, in more low, and now we also have trials going on for using it in estrogen positive breast cancer, because it may also give a good option in the estrogen positive breast cancer, as a further option, after they have gone through anti-estrogen chemotherapies. This may be additional option. And at least in triple negative, the response rate in some of the heavily treated patients was twice as much as of another chemotherapy agent. So definitely a good addition. There are also some new drugs coming around, like taxanes in oral formulation are being tested, again, to minimize need for IVs and trying to treat the patients outpatient. Before I forget, I do want to mention, it already made a change in my practice. Last couple of weeks, there was a new data published that giving immunotherapy, again, the treatment we discussed about before, in triple negative breast cancer in an earlier stage. So let's say somebody has high stage 2 or stage 3 breast cancer. We know we have to give them chemotherapy. In this trial, the immunotherapy was given along with the chemotherapy before surgery, then along with the chemotherapy after surgery, and then patient was maintained on immunotherapy for 6 months time afterwards. And what it showed was when we gave immunotherapy along with chemotherapy into the patient with triple negative breast cancer, the complete remission, meaning there was no cancer found at surgery, that rate doubled. So clearly it increased the effectiveness of chemotherapy in many of these triple negative patients. So this data just got presented this month, and we are looking at immunotherapies and making immunotherapies more effective in more patients in many different ways. But this data was just presented a few weeks ago. So now there is a change of practice going on where we are trying to, and the FDA approvals are still pending to a degree, but we are already trying to give patients immunotherapy along with chemotherapy in a high stage, triple negative, early stage breast cancer, along with their chemotherapy, so that we can have a better response and then a better outcome for these patients. So with that, I think there are other many exciting new drugs coming out. We are looking at other targets, other antibody drug conjugates. And now that we have figured out how to combine different drugs with different kinds of antibodies, these kind of drugs are also being used in many other cancers other than breast cancer. So, it may not be obvious to everybody, but if you really look at it, in last 25 years, the cancer death rate has gone down by almost 29% in one of the study I saw. So any cancer, basically. Of course, there has been a lot of research and a lot of advancement in breast cancer. We are still not curing stage 4 breast cancer, unfortunately, but we are keeping women alive longer and with much better quality of life in a lot of situations. There is still a lot to be learned, but hopefully we'll get there. Okay, so I guess I will go through some of the questions now. Okay, let's see. Right, so again, if you have not entered, please and put the questions through the Q&A sessions, and I'm going to open the Q&A questions now and see what I can find. Okay, so the first question, patient had lumpectomy and radiation for breast cancer 25 years ago with a low-grade early stage tumor, but it recurred 25 years later, it looks like. So yes, one of the thing is, I'm going to minimize it again. One of the things is the HER2 positive and triple negative breast cancers, usually if they recur after earlier stage diseases, they will recur usually within 5 years, okay? The highest risk is first 3 years, and after 5 years or so, there is minimal risk. That is not the case for the estrogen positive breast cancer. One of the change that has taken place is in many cancers, even in stage 1 cancer, sometime we are advising longer duration of anti-estrogen. Of course, that comes with its own side effects. So it's an individual decision, looking at that patient's tumor and looking at some additional testing that we may do on the tumor to see what the benefit versus side effects for the patient are. But clearly, most of the patients are not going to be on anti-estrogen 20 years out. And there is a small but definite risk of breast cancer recurrence in estrogen positive breast cancer, even after 20 years. I've usually seen in a higher stage patient, but once in a while it can happen in a lower stage. The other possibility is that there may be a new estrogen sensitive breast cancer that just has not been identified or localized, okay? So I'll go to the second question. Okay, if the tumor is estrogen receptor positive as well as HER2, HER2 positive, then what are our options? It depends on the stage. Our first goal will be to direct the treatment to HER2 new directed treatment. So in a neoadjuvant setting, in an adjuvant setting, later on we will give the patient an anti-estrogen, and we may give them an anti-HER2 new directed treatment later on also. But the HER2 new therapies are for definite duration in earlier stage HER2 new tumors, but anti-estrogen can go on for longer. In a metastatic stage situation, if there is limited metastatic disease, then we can maintain them many times with trastuzumab along with an anti-estrogen for long periods of time. So those are pretty reasonable options to combining the two agents, but it really depends on the situation. All right. HER2 new, somebody asked me to spell it H-E-R and number two, okay? I've been on 2 types of AI, but I've had severe body aches with both. Is there a different kind? So yes, joint ache, especially in patients with underlying arthritis, can be a significant problem. Most of the time, one uses anastrozole or letrozole, which have very similar side effects. I have found many times less side effects in patients who have estamestane, which is a third AI. Sometimes the insurance companies give a hard time approving it and covering it as well, but there are, I've appealed it and have been able to get it for the patient. The other option is to go back to tamoxifen. That's a reasonable option in some patients if they cannot tolerate the AI. And in some patients, especially if somebody has a second breast cancer and they already were or they had just stopped the AI, Faslodex is an option too, and has a different side effect profile. The problem with the Faslodex is it's by injection, so it's inconvenient, and getting injection is not fun also, but the side effects are usually less. And hopefully in future we will have oral form of something similar to Faslodex and may give us another option, but not quite there yet. Okay, let's see. Yes, the first part I could share the slide that makes it difficult. And when I needed my slides the most with the more complicated new drugs, names, and methodology, that's when I lost it. I will see if there is any way for me to get these slides to you guys and see if that helps. And maybe that will help. I didn't want to interrupt the talk to spend a lot of time because this computer has been giving trouble today. Okay, Zomera infusion in estrogen progesterone positive breast cancer. So Zomera is, as some of you know, is a biphosphonate. It is something that is used for moving the calcium to the bones. So it has multiple different reasons to be used in breast cancer and other patients. It's something that can be used for patients who have high calcium. It can also be used for improving the bone density in the patient. More often, we are using Prolia-like drugs or denosumab, which is Xgeva, for helping with the bone mets pain, but Zomera has been used in the past. The reason we are preferring the other drugs is because those drugs are not IV, so it's easier for patient to get. But Zomera performs the same function, and they don't have as much cancer-directed benefit. There has been studies actually looking for them if there's a direct cancer benefit, and there is a slight benefit, but it is fairly small. So there has to be another reason for using these drugs usually, but I'm not opposed to it in the right patient. Okay, BRCA1 and 2 gene mutation. What other genetic tests are available for breast cancer screening? A little bit different. Breast cancer beside BRCA, no, those are genetic tests. Those are not for screening for breast cancer. And these patients not only have a risk for breast cancer, they also have risk of ovarian cancer and other things. So when we are talking about cancer screening, that's a separate talk about, role of mammograms and ultrasound and MRI scan and how to use that technology. In terms of, genetic testing, again, we have to a degree, individualize beyond BRCA1 and 2. We are checking for other genes. These days, many of these tests are done as a panel. So multiple other genes are tested. So we can individually talk about depending on what gene test is positive. Okay. All right. So yes, this is an interesting question. Somebody mentioned that they are only 10% estrogen positive and 0% progesterone positive and 0 for HER2. And it is being treated as triple negative. That is correct. You have to look at, just because something says positive, you have to look at what percentage of cells are positive and how strongly they're positive. Most of the time it will mention percentage. It will also say weak, intermediate, or strong. So what 10% means that only 10% of the cells in the biopsy had estrogen positivity. What that also means that 90% are estrogen negative, okay? So for the most part, that is a triple negative cancer. So, and for most part, it needs to be treated like an as a triple negative cancer, unfortunately. Okay. All right, where can we watch this recording? I think maybe the cancer support community will have this recording, and I believe UCLA website will also have this recording available, and I'll try to get the slides put in there also. So hopefully that will make sense. Okay, now let's go to a terminology I did not use that is being asked in a question, triple positive. What is triple positive? Triple positive means estrogen positive, progesterone positive, and HER2/neu positive, okay? They basically, and it is, yes, so when we are using estrogen, when we're using HER2/neu directed therapy with chemotherapies, or we're using something like Kadcyla, which is TDM1, which is Herceptin with the chemotherapy, the response to the chemotherapy, anti-HER2/neu directed therapy may be slightly less than in ER negative tumor. The difference is the ER negative tumors are also fast growing. So faster growing cells also have a faster kill. So you're going to have a better pathological complete response in tumor which are estrogen negative and HER2/neu positive. And triple positive, which is the terminology used as opposed to triple negative, is estrogen positive, progesterone positive, HER2/neu positive. The good news though is even though sometimes the responses can be slower, we have much more options available. So let's say if I have a high stage 2 or a stage 3 triple positive breast cancer, they may get TCHP neoadjuvant, they have the surgery, let's say they have some remaining tumor present, they'll get TDM1 or Kadcyla, they will finish their radiation if that was warranted, and they will also get an anti-estrogen therapy added to that. So definitely a good, and then once they finish their Kadcyla, they will continue on to, HER2/neu directed therapy. In some patients, even response-wise or non-response-wise, it's good to change agents. If they've had that, there are situations if a patient is not able to tolerate Kadcyla for whatever reason, I may switch them back to Herceptin. We may even give Herceptin and pertuzumab in an adjuvant manner. And then later on, the anti-estrogen are combined also. So those are all good options. It's a little difficult for me to read all these long questions that quickly. I always prefer in-person meetings, of course, so this makes it a little trickier for me. Why immunotherapy is an option after surgery if surgery is removing the tumor after chemotherapy? Well, that brings a very important question in any situation, okay? So why do we do adjuvant treatment? Once a surgeon put it as, oh, I have removed the cancer, now the medical oncologist will come and do a mop-up job. Very crude way of putting it, but that's very true. Just because you had scans before the surgery, let's say even a PET scan showing no spread of cancer anywhere else outside of breast and lymph node, and the surgeon took out the cancer, even if somebody had mastectomy and lymph node dissection, why do we recommend additional treatment of any kind, whether it is chemotherapy, whether it is anti-estrogen, HER2/neu, or immunotherapy? Because you have to realize that PET scan will not show cancer less than 5 millimeter. And 5 millimeter cancer deposit is several million cells of cancer. So our most sensitive scans are not able to find cancer cells which may be present in bone marrow, in other organs, even if our scans are not showing it and any blood tests are not showing it, okay? So the job of the systemic treatment in adjuvant form is to try to eliminate those cancer cells that have left the primary site and gone and hiding elsewhere. That's what gives a risk of cancer coming back. If those cancers were not present, if we knew how to find every cancer cell elsewhere and find out where no cancer cells have gone, we will not need to give any adjuvant systemic treatment of any kind. So when we are talking immunotherapy also, and that's what the question was, but the same applies for chemotherapy and anti-estrogen. We're trying to go after the cancer cells that are hiding elsewhere and we cannot see. That is what gives, when when a physician tells you, okay, the surgery is done, but you have a 20% risk of cancer coming back, or you have a 70% risk of cancer coming back. We are making those estimation based on the stage of the tumor, biology of the tumor, and we can't see that cancer, but clearly on those patients the cancer will come back, and we're trying to minimize the number of patients where the cancer will come back by giving them additional treatment. Okay, so the same concept applied, all adjuvant. Okay. I did not understand this one question. I think let me check if we have more time for more questions. So Xgeva is like, that's like an injection for the bone density. And some people are asking this question. Ibrance and letrozole. Okay, there's a question here. Xgeva, Ibrance, and letrozole. Yes, fairly reasonable in metastatic setting, usually in hormone receptor positive, estrogen receptor positive tumors. If they present, the first line treatment is usually anti-estrogen in the form of Faslodex or letrozole, along with Ibrance, which is a CDK inhibitor, but can be any of the other CDK inhibitors. And one, if there is bone mets, one will give Xgeva-like drug to keep the, that helps keep the problems from the cancer in the bones. Okay, let's see more questions. Yes, lobular, we will be going off track here. But yes, lobular cancer is harder to see in mammograms, especially. They're also a little bit harder to feel because they are somewhat softer in their feel. But they are more often estrogen receptor positive, which is a good thing. And they can be, MRI will usually pick it up. They will eventually form a mass, and ultrasound sometimes can help diagnose them also. Okay. Yes, so let me see. Okay. All right, so yes, there is a question about somebody had surgery and radiation and was hormone receptor positive. So she was on anastrozole or Arimidex for 2 years, 5 months, and now has a breast cancer, another breast cancer. These are again, so what happened here? So basically there are, why do we have to change drugs in patients? We know the cancer cells can become resistant, okay? Why are the cancer cells become resistant is, one second. Okay, hopefully you can see this thing that's in my screen. I'm trying to remove this. This keeps on causing problem. So, sorry. Okay, sorry again, this keeps opening. Okay, why do the cancer cells stop responding to anything? Because they develop secondary resistance. So there are many different ways cancer cells can become resistant to estrogen directed therapy, to tamoxifen, to anastrozole and other things. And that's why we need to change the category of drugs. So yes, going to tamoxifen after anastrozole may be an option. Not always my preferred option. I guess depends on the situation and the patient. I would usually go to something like Faslodex after the tumors come back while the patient is on an Arimidex. I think tamoxifen may be less likely to work, but one can try it. Definitely no harm in doing that. But my first preference probably will be to go to Faslodex. Since the tumor is clearly resistant to Arimidex, I will probably be concerned that tamoxifen may not be as effective. Okay, Um, okay, hormone one is negative, other is positive. It's saying in that question, well, that patient probably also need chemotherapy, and then it really depends on depends on how, what's the different tumors in there, if there are multiple tumors. Sorry, so I'm going to move from that question. Kadcyla and Keytruda, good. So it looks like somebody has two breast cancer. One was HER2 positive and one was triple negative. So the patient received, for HER2 positive TDM1, and for the triple negative Kadcyla. So yes, we have to think about outside the box many times. Tumors don't always come in three categories that we talked about. And there are times where there may be more than one kind of cancer. So we do need to deal with that. And also one of the things that happens also in advanced stage breast cancer is that there may be differences in tumor in different parts of the body. So one part of the tumor may be still anti-estrogen responsive or estrogen positive, but another met may be in, say, in the liver or lung, may not be responding to the anti-estrogen. So we have to, if the things are not going well, if the things are not making sense, what that means is we need to look some more, okay? And we need to investigate and think of outside the box when we need to go outside of the box. Doesn't make things easy, but we do need to do that. So let me see. Let me see if we need to do more questions. Okay. What can we do as patients to get the best out of treatment? As patients, yes, I know every patient wants to do well. Every patient wants to be able to tolerate the treatment so they can get the maximum benefit. One of the things is to have an open mind, okay? And that goes both for the doctors and the patients, okay? Sometimes things don't make sense, but they just work out, okay? And one of the things I tell my patients is hope for the, you can prepare for the worst. You should prepare for the worst. And that, if nothing else is COVID-19 is telling us today also, you never know what's around the corner. And I know it's doubly stressful for my patients dealing with COVID-19 and dealing with their cancers and their treatments. But nobody expected that, but this happened and we have to deal with it one way or the other. So we never know what's around the corner. Hopefully it is positive, but always hope for the best. And keep an open mind. Don't go with preconceived ideas that this treatment is not going to be tolerated or that treatment is not going to be tolerated. In fact, I had to learn from my patient also. One of my patient, she may or may not be on the talk, she had in the past breast cancer, had tried to take tamoxifen and could not take it, okay? Years later, she had a second breast cancer. She had to go through chemotherapy again. And she again tried anastrozole, would not think about trying tamoxifen because she really tolerated it poorly. She could not tolerate the anastrozole at all. I tried to get her to take estamestane. She could not tolerate that very well also. I wanted to get her to try Faslodex, but because in her situation it was very important, we gave her anti-estrogen. And that especially in the COVID-19 era, it was something, she had to drive down to try to get 2 shots every 4 weeks. That's not something they wanted to do unless they absolutely have to. She asked me to let her try letrozole because one of her friends was taking it and tolerating it well. My first thought was, and I told her that most of the time letrozole has same side effects as anastrozole, and it's very likely if she cannot tolerate anastrozole and aromacin, she will not tolerate the letrozole also. But because she wanted to try it, I said, okay, let's try it. And to my surprise, she tolerated it fine, and she's taking it and doing well on that. So, I really did not think she'll tolerate it well, and she wanted to try just because maybe it was the positive suggestion from her friend that helped. But, whatever works. So we all need to keep open mind, doctors and patients, and, don't give up. And, because I find patients who go into treatments with positive attitude will usually do better. Overall, yes, of course, there is differences in patients' tolerability. One drug may be better tolerated in one patient and one drug may not be as well tolerated in another patient. So we can go over the side effects. We can talk about what we can do to minimize side effects and tolerate the side effects. But at the end of the day, one has to try and see what one does. And, I think the positive attitude also helps there. And it is difficult sometimes to keep a positive attitude when you've had bad experiences, but we all need to try. Now, one of the things that changed, one of the things I want to absolutely mention, you are all hearing patients with cancer at a higher risk of COVID-19. That is true to a degree. Take everything with something. We all need to take precautions. We all need to be careful, young and old, patients healthy, other conditions or not, okay? But all cancers are not created equal. So somebody who is going through chemotherapy for stage 4 cancer, advanced disease, other health issues, those patients are definitely at a much higher risk than, say, somebody with stage 1 breast cancer who is not on chemotherapy, maybe on an anti-estrogen, or had chemotherapy but was a year ago or longer. So, these are all shades of gray. We all need to take precautions, and we all need to be careful, but don't be so fearful about your cancer diagnosis making you so much higher risk, okay? It varies from patient to patient, and if you have a question, talk to your doctor. It depends on so many different factors that add on to the risk or decreases your risk of COVID-19. So similarly, patients with lymphoma, myeloma, leukemia, they definitely have a much higher risk than any breast cancer patient in that regard, if you have the same age and other health conditions are the same. So don't be as worried about it in that degree. The second thing I do want to mention, I know the screening mammograms were held for a while because of the COVID-19. They are being done again. Hopefully they don't shut down again with this increased numbers recently. And surgeries are being performed, yes, but of course, if somebody needs bilateral mastectomies with immediate flap reconstruction, those are big surgeries, require hospitalization, and one may choose to delay it. For some time, some of the very early low, small tumors, well-differentiated tumors, the radiation was delayed also, and we gave them an estradiol-like drug and to take while they were waiting to do their radiation. And hopefully these adjustments with COVID-19 will not go on longer, but they are still going through. But the worst thing we can do is to let the cancer grow and spread. And, that's the concern, that we will be diagnosing some cancers late because the patients are not having their screening tests. Some patients are actually delaying going to the doctors even if they feel a lump, and that could be really bad, some thought of consequences of COVID-19 and lockdown. So please, everybody, take precaution and go from there. Is Arimidex is a good anti-estrogen treatment? Yes. In premenopausal women, we have used tamoxifen quite a bit, but even in them, there is studies showing if we turn off their ovaries with Lupron and give them tamoxifen, and even better still, if we give them Lupron and Arimidex or letrozole or something like that, those are better. If a high-risk patient, it does add more side effect, but it does give better outcomes. If to make the patient menopausal if they're not menopausal, because you have to be menopausal to use anastrozole, letrozole, aromacin kind of drugs, and make them menopausal and give them one of those drugs. These are better drugs than tamoxifen are. But in some situation, you have to also maintain quality of life and see what you can keep the patient on, okay? So discuss always all options, weigh your risks, benefit, tolerance issues, and see what is the best option for you. Okay, P53, okay. P53 is a gene mutation that is checked in many tumors. It makes, and it can be present in many, many tumors, not just breast cancer, but many other cancers. We have not been very good. There are some drugs being tested now, but we have not been very good so far in how to deal with that problem. What this gene mutation does in any cancer cell is makes it more aggressive and also makes it somewhat resistant to certain drugs. So that's the difficult part of P53. It makes the tumor more resistant and more aggressive. And that can be a problem. And there are drugs being tested to attack that gene mutation in cancer cells, but not quite there yet. Okay. Positive. Okay, if you have an ER and PR hormone positive breast cancer and HER2 negative, you get Taxotere and Cytoxan chemo, and cancer is back. Is the next treatment to get CD4/6 inhibitor or another type? Okay, so if somebody has had chemotherapy after their tumor, the first question I will ask is, how long ago was the chemotherapy? Was the patient on anti-estrogen? If the patient was on an anti-estrogen, till when? How long between the last time the patient took was the patient currently on an anti-estrogen, or was the patient on never took anti-estrogen because they could not tolerate it? And all those things have to be looked at in making a decision as to what is the best option. But if the metastatic cancer is, and again, you will biopsy the tumor again and make sure it is the same kind. If the tumor is estrogen progesterone positive and HER2 negative in a stage 4 condition, patient had prior adjuvant chemo probably because it was a higher risk cancer. And if the treatment happens during, let's say, Arimidex, if the recurrence happens, then of course I won't use Arimidex. I may use Faslodex and a CDK inhibitor. If the patient has not been an anti-estrogen, then any of the AI or Faslodex and CDK inhibitor is a good option. We will only start with chemotherapy if there is a reason to start on chemotherapy. What I mean by that is, if somebody unfortunately presents with a very fast growing aggressive cancer and the liver is full of cancer, lungs are full of cancer, and the patient I know will get into trouble very, very quickly unless I can get a response, I may do chemotherapy and even combination chemotherapy in that situation. That is not a situation in most of the patients. So we can start with an anti-estrogen based, CDK inhibitor based treatments in those patients and utilize those things and delay chemotherapy till later on. Okay, so yes, for most of the patient, using those drugs as a first option for stage 4 ER positive tumor is a good option. Okay, part 2 of somebody's question was, if I'm 10% estrogen positive, would you treat me with estrogen therapy for anti-estrogen, you probably mean, for 5 years afterwards? Okay, so if the tumor is only 10% positive, should that patient get an anti-estrogen? The answer will be, we will try to. If the patient has a higher stage cancer, and if I can easily get that patient to take that anti-estrogen, and maybe this is the case where I will not go for something that's causing a lot of side effects, but maybe if the patient has had a hysterectomy, maybe use tamoxifen. Or if somebody doesn't want to, has osteoporosis, has arthritis, has having a lot of side effects from an anti-estrogen, then yes, one can forego an anti-estrogen. But if they can tolerate it, I will try to use the one which they can best tolerate it. I may even use something called raloxifene, which is Evista. It is not approved for adjuvant treatment of breast cancer. The 2 indication for raloxifene is, one is to prevent breast cancer. So it is used in DCIS, so non-invasive breast cancer, or it is used in other precancerous breast condition like atypical ductal hyperplasia or atypical lobular hyperplasia to decrease their risk of estrogen positive breast cancer. The second indication for raloxifene is to actually help with the bone density. So you have to weigh in. If the tumor is only 10% positive, you have to weigh in the risks and the side effects and the benefits to the patient and the tolerance for the patient and see what best works for the patient. But it is not wrong to recommend an anti-estrogen, even though the reason, we are considering in some ways triple negative, but we are trying to give the maximum benefit. But if I can combine additional benefit, like with the raloxifene and help them with bone density, then I'll go that route, okay? So let's see. I think we are pretty well done. And, you know, osteonecrosis, those things, that's a complicated question. You know, Exgeva and Zomera like drugs. Yes, if you take long-term those drugs, there is some problems with certain bones. The bones that are formed are not normal bones and they can be weaker. But at the same time, taking these medication for a certain period of time, the benefits outweigh the risk. Again, you have to individualize and make decisions with the patient. Definitely keep the duration of these medications under 10 years. Also in a metastatic setting with bone mets, you know, the benefit is much more, but again, I may not keep giving them monthly, which is what is indicated. I may start monthly, but I may give them every 3 to 4 months only, or may even give it less often if they've had a lot of shots already. So you have to make decisions with your physician as to what is the risk benefit and what is your best option. Okay. I think with that, we should end. You know, I'll see if there's anything else. I think that should be good. And so if there is any thing else additional, I think the cancer support group will let you know if there is a posting online there. I think they do that. And also UCLA website will have a posting of this video, so you can access it that way also. And I'll try to get my slides, which were actually simple, just lists of things. And I'm actually you know, concerned that I was not able to show you, just because it makes more sense when I'm talking. It's easier in person because the slides are right in your back. Okay. So thank you very much, everybody. And best of luck for everybody. Keep safe. And I know it's unusual ways to get your questions answered and to get support, but let's hang in there. This shall pass too. Okay. Take care, everybody.